We're going to discuss today the results of the CAMIA and the CAMIA Plus projects. In this lesson, we are going first to describe the methodology of cause of death attribution based on the MIA or MITS findings. Second, we are going to describe the methodology that we have used for cause of death attribution based on the complete autopsy. Third, we are going to understand the methods of evaluation of the agreement between the MIA or MITS and CDA, the complete autopsy. And fourth, we are going to discuss the main results of the MITS in adults, children, stillbirths, neonates, and in maternal deaths. I would like to emphasize that I am going to use MIA and MITS with exactly the same meaning. We have been using MIA, minimal invasive autopsy, for many years. In the last few years, minimal invasive tissue sampling has become an alternative to the original name of minimal invasive autopsy. I would like to emphasize as well that complete autopsy and CDA, complete diagnostic autopsy, are again have the same meaning. First of all, I'm going to present briefly the two studies, the CAMIA and CAMIA Plus project that we have been conducted in the last few years. The CAMIA study started in 2013 to 2015, was the first study related to minimal invasive autopsy that we conducted in our institution, the Institute for Global Health in Barcelona. The study was coordinated by our institution in Barcelona. It had two components, as you can see here in this slide, in this dark blue or purple, the two sites where the validation study was conducted. When I say validation study, I mean the validation of the minimal invasive autopsy against the complete autopsy. And this was done in Mozambique, in the Maputo Central Hospital, in the capital of Mozambique, in Maputo. And the second site was Manaus, in the Brazilian Amazon. The study had a second component. This component was a social science component, so evaluating the acceptability and what we can do to increase the acceptability of this method in the different populations. And this study happened in 5 sites, trying to cover different social and religious backgrounds. So first of all was Mali, in Western Africa, basically a Muslim country. Second was Gabon, also in Western Central Africa, mainly Christian. The third one was Mozambique, mainly Christian country, but with about 10% of Muslim population, located in southeastern Africa. Kenya, in Eastern Africa, mixed Muslim and Christian population. And finally Pakistan, in southeastern Asia, a country 99% Muslim. Regarding the validation study, the first thing that we did in this CAMIA study was to develop the standard operating procedure. This standard operating procedure was initially developed in adults and has been the basis for all the studies doing MIAs or MITS that are now ongoing in developing countries. This first CAMIA study involved all age groups, not only stillbirths, neonates, and children, but also adults and maternal deaths. After this study that finished in 2015, we started the second project called CAMIA Plus that started in 2016 and concluded at the end of 2018. The objectives of this second CAMIA study was number one, to continue the validation of MIA or MITS against CDA in pediatric deaths, now focused specifically in pediatric deaths. For this we included 100 cases for each group: stillbirths, neonates and children under 5. Second, we tried to enhance the MIA methods for some specific conditions that were not specifically covered in the first CAMIA study, and basically diarrheal diseases, so including the study of the stool, malnutrition, and for this we included anthropometric data such as weight, height, etc., and some biochemical parameters, and finally anemia, including hematological parameters such as ferritin, transferrin, and etc. Third, we have evaluated the diagnostic yield of MIA performed at different time points after death. So in the first CAMIA study, the limit for conducting a MIA was 24 hours after death. All cases after these 24 hours were initially excluded. However, we assume that this was not possible in some situations, and in some cases the bodies arrived to the pathology lab later than 24 hours after death. So what we wanted is to determine whether these bodies were still acceptable, or the results provided by the study of these bodies are still adequate for diagnosis. For this, we have included a group of bodies in which we have done consecutive MITS, repeated MITS at 24, 48 and 72 hours, and compared with the results of the complete diagnostic autopsy performed at 72 hours after death. The fifth objective was establishing a transnational training and research center for post-mortem investigation, what we call training and research in post-mortem activities, or TREMA Center, with headquarters divided in Barcelona and Maputo, and with an specific emphasis in developing the technical resources and the human capacities for training technicians and training pathologists. This is the first slide showing results, and the first result I'm going to show is the successful in terms of number of cases in which we obtain the different organs. As you can see, the minimal invasive autopsy is very successful in getting liver. So in all the cases we have identified liver in the samples. So it was very successful as well for central nervous system. So it's again 100% of the cases. It was almost perfect for lung, but I'm going to add some comments in the next slide. And we were less successful for kidney, heart, gastrointestinal and other organs. So I should stress that in the first CAMIA study we specifically targeted kidney and heart. However, in spite of trying to get samples of these organs, we were successful just in about 50% of the cases, as you can see in this slide. So this means that getting kidney and heart is not that easy. So in addition to the organs that were targeted, that are liver, CNS, lungs, kidney and heart, other organs not initially targeted were obtained in some cases, and you can see that the gastrointestinal tract, adrenal gland, spleen and others were obtained in some cases. Although we got samples of all the organs, I would like to show this slide. This slide shows the square millimeters of each organ obtained histological samples. So as you can see, the amount of liver was quite good, as it was the amount of CNS. But for the case of lungs, although we obtain lungs in almost all the cases, the amount of tissue, the volume of tissue that we obtain in these samples was very low. So as you can see, the square millimeters, the mean square millimeters area was less than 10. This means that we obtain less amount of lungs than liver or CNS. And this is relevant. So these are again all the data I am presenting come from the first CAMIA study, because as you can see, the most informative organ, as you can see in this slide, the most informative organ is the lung. So in 46% of the cases, the diagnosis, the cause of death was identified in the lung. So this means that the lung is very informative. In most of the cases, the cause of death is precisely in the lung. So this has resulted in the current protocols, in the current SOP, and this is something that I want to emphasize. The lung is very important. To the current protocols, the current SOPs have included a significant more samples of lung than the first SOP, and we try to get, and you should try to get as many lung samples as possible, because this is the most informative organ. As you can see, CNS and liver and heart are the second, third and fourth organ, but far less than the lung in terms of information regarding cause of death. This is an example of the samples that we get using this technique, the MITS. So this is a sample. The first is how these core biopsies look like at low magnification. This is liver. The second one is a sample of the lung, and we can apply to these materials, as it's shown in this upper right picture, special stains such as glaucon, methenamine, silver, or in the lower row in the left, PAS stain. And I want to emphasize that in addition to that, in addition to the histological sample, we applied microbiological studies, both classical, and this is an example of a culture, and molecular as well. So with the samples, after we had completed the analysis of the pathological and the microbiological samples, we created a death attribution panel that used all this information provided by the microbiology and the pathology. This death attribution panel is composed by a pathologist, a microbiologist, and a clinician. I want to emphasize that, and this is something that we have used in all our CAMIA and CAMIA Plus studies, that we wanted to know the performance of the technique by itself, without the use of the clinical data. And most of the results I'm going to present are based on these two findings, just the microbiological and the pathological data. So what we wanted to know is, if we identify a body with no clinical information at all, what is the information that we can provide using just the analysis that we can do with the MIA samples. So the findings that we evaluated, that this death attribution panel evaluated, were just the MIA histology and MIA microbiology. So with the information of these two analyses, we assign what we call the MIA diagnosis, so the disease or condition putatively leading to death, or hypothetical leading to death, using just these two analyses. And we use the ICD-10 coding, using the rules that this ICD-10 coding provides in terms of calling in diseases, immediate cause, underlying disease, and associated conditions. An important feature that I want to emphasize is that MIA is a blind sampling. So we do not know whether the area of the lung or the liver that we observe under the microscope is representative of the lesion. As you know, many lesions in the organ do not involve the whole organ but involve a specific area. So, in some cases, we had in the histological evaluation a strong evidence, and I'm showing in this picture two cases, a meningoencephalitis and a pneumonia on the right side, very clearly identifiable by the histological analysis. However, in some cases, this evidence was much less, much milder. And I have here in the left side two examples of this. This is a brain sample showing some mild inflammatory infiltrate, but nothing clear, and the same for the lung in the lower image. So some hemorrhage in the alveoli with some inflammatory cells, but again nothing very evident. So in some cases we had a very nice, strong evidence. In some others the evidence was much less. So then we created a classification or a grading of these findings. So classifying the evidence in the histological and the microbiological findings from 0 to 4. 0 none, so nothing there. Normal. 4 very clear findings indicating the cause of death. So in between we had cases with moderate, fair, or slight evidence, and the same for the microbiology. 0 indicating that no microorganisms identified, 4 indicating microorganisms very clearly responsible of the death, and in some cases we identified either contaminants or microorganisms that could represent true pathogens or contaminants. I invite you to review this classification because it has been published in PLOS Medicine. So then, combining the strength of the findings identified in pathology and microbiology, we evaluated the certainty of the diagnosis, how sure we were of the diagnosis. In some cases, we were pretty sure about our diagnosis. In some cases, this evidence or this certainty was moderate. In some cases, it was very low. So we had a cause of death, but the certainty about this cause of death was very low. This table shows a few examples. So, septicemia on the left. We applied this methodology to the complete autopsy and to the MIA samples. Obviously, as you can see in this slide, so we have on the left side the strength of the findings and the certainty of the diagnosis in the complete diagnostic autopsy, on the left in the MIA. So this is the same case. So 51 is the evidence and the strength for the CDA on the left, and on many of the cases we had this very high evidence, both with the complete diagnostic autopsy and with the minimal invasive autopsy. So, and this shows exactly the same with real data. As you can see, the diagnostic certainty in the complete autopsy was very high, in a very high percentage, 92%. For the MIA, this very high certainty was for 63. Moderate, we had 13%. Low evidence, we had 13%. And as you can imagine, in a not significant, but in some cases, in the minimal invasive autopsy, we were not able to reach a diagnosis. So in 11% of the cases, there was no diagnosis using the minimal invasive autopsy. As you can see on the left diagram, this happens as well with the complete autopsy. We all know that even after doing a complete autopsy, in some cases, the cause of death cannot be determined, and this happens in a small percentage, 3% of the complete diagnostic autopsies in our series. This is just to show the ICD-10 classification. This is a website, an open website of the WHO that you can find in your internet very easily. And this is an example of a few cases. We tried to identify this column A, means the immediate cause of death, so the last event leading to death. Column D is the underlying disease. As you can see, in our cases, HIV was the most frequent underlying disease. I should say that Mozambique is an area with an extremely high prevalence of HIV infection. In some cases, we could identify a chain of events, and I want to show this case 164, so the third line. As you can see, the patient has an underlying disease, HIV. This HIV led to Burkitt lymphoma. This Burkitt lymphoma, combined with the HIV, led to two different infectious diseases, extremely severe infectious diseases that were disseminated, CMV and pneumonia caused by CMV, which was considered as the final cause of death. In addition, this case had another condition that was not involved in this chain of events leading to death, that was identified and was diagnosed by the minimal invasive autopsy, and this was malaria by falciparum at low levels of parasitemia. These are a few examples for the complete autopsy, exactly the same. So in this case, as you can see, we were able to identify more diseases. I want to stress that for the complete diagnostic autopsy, in addition to the microbiological and pathological data, we used the clinical data as well, and obviously the gross data, the macroscopic information. This is how complete diagnostic autopsies are conducted, how pathologists usually do these complete diagnostic autopsies. So this was the gold standard, so we wanted for this gold standard to have all the available information. Well, for most of the comparisons, we used this simplified classification, including four major diagnostic groups of diseases. First, infectious diseases. Second, malignant neoplasms. Third, other diseases, including non-infectious cardiovascular, gastrointestinal, kidney and lung diseases. And finally, non-conclusive, meaning that we did not have a good diagnosis. So, as I said a couple of minutes ago, for the CDA, in addition to the histology to the microbiology. We used the gross examination, so the macroscopic evaluation of the organs, and we used as well the clinical history. So we used all the information. So then, to reach the cause of death with the complete diagnostic autopsy, we had another death attribution panel. It was a completely different death attribution panel composed by different members, but this death attribution panel had a pathologist, a microbiologist, and a clinician as the minimal invasive autopsy death attribution panel. So in this death attribution in complete autopsies, we evaluated, this death attribution panel evaluated the CDA histology and the macroscopic findings, the CDA microbiology, and the clinical history. And we assigned the CDA diagnosis of the complete autopsy diagnosis, which was our gold standard, against which we compared the results of the MIA. And we did exactly the same. So we coded the diseases, the different diseases identified in each case using the ICD-10 coding system. And this was our gold standard. This graph shows the diagnostic process that we followed for the MIA and the complete autopsy. So the MIA was done by a pathologist, pathologist A, and the samples obtained were for histology and for microbiology. Regarding the analysis, what we analyzed was the histology and the microbiology using molecular and cultures, and for the cause of death attribution, we had this pathologist, microbiologist, and clinical epidemiologist evaluating just the results of the histology and the microbiology with no clinical information, no macroscopic information. The complete autopsy was done 1 hour after the MIA, was done by a different pathologist who had no idea of what the pathologist A did in the MIA, as the pathologist of the MIA had not either information on what happened with the complete autopsy. So this complete autopsy, the samples taken were histology and microbiology again. The evaluation was done exactly the same, independently by a second team, histology and microbiology, and for the cause of death attribution panel, again, pathologist, microbiologist, and clinician, different team, evaluating not only the results of the histology and microbiology, but also including in this information the macroscopic data and the clinical data. Well, these are the results I'm going to present. So these are the results of the CAMIA study. So we included for adults 112 cases. As I said before, Mozambique is an area of high HIV prevalence, and 65% of our patients were HIV positive. For the maternal deaths, we included 57 cases, again a high percentage of them HIV positive. For the case of children, we included 54 cases, 32% of which were HIV positive, and of these 54, 32 were 1 month to 5 years. For the neonates, we had 41 cases. In 70% of them, the mothers were HIV positive. 29 of these 41 were early neonates, and 12 were late neonates. And for the case of stillbirths, we had just 18 cases, 12 intrapartum and 6 12 antepartum and 6 intrapartum. So this, as you can see on your right, so this is the overall prevalence of HIV in Maputo area and the prevalence of malaria. So it's a high HIV prevalence, a low malaria prevalence in the area of Maputo. In this slide I have summarized the definitions that we have used to evaluate the concordance between the MIA and the complete autopsy. Just because I'm going to refer continuously in the next few slides, I would like just to briefly discuss the definition of each particular word. So agreement means the proportion of cases in which the diagnosis reached with the new method. So the MIA is exactly the same as the gold standard. The kappa statistic is a statistics that evaluates the observed agreement adjusted for the agreement expected by chance, so the concordance. Sensitivity for a specific diagnosis means the proportion of cases that were diagnosed correctly. Positive predictive value, or PPV, means the proportion of truly positive cases between those that were evaluated initially as positive. False negative diagnosis means the number of cases estimated as not having died from certain disease but who died of that cause. And finally, false positive diagnosis means the number of cases estimated as having died from a certain disease but who did not die of that cause. Well, this slide summarizes the agreement between the MIA, blind to clinical data, I want to emphasize that, with the complete autopsy. So as you can see, the agreement was quite good for all diagnostic groups. In this column we have in the center we have the agreement, and on the right we have the kappa. As you can see, the agreement ranges from 68% for the maternal deaths and the neonates to 89% in children 1 month to 15 years. And in keeping with that, a kappa statistics range from 0.4 or 0.48 in neonates and maternal deaths to 0.7 or 0.8 for the children, stillbirths and adults. So the concordance according to the kappa statistics range from moderate in neonates and maternal deaths to substantial for children, stillbirths and adults. Interestingly, when we added the clinical data to the pathological and microbiological data to the MIA evaluation, so what we did is, in a first evaluation we used just microbiology and pathology as I stated, and we had the results that I presented in the previous slide. In this slide I'm showing the results of a second evaluation in which, in addition to the pathology and microbiology, we added the clinical information. So as you can see, for all the groups there was an increase in the concordance, an increase in the kappa statistics that for the adults went from substantial to almost perfect, for maternal deaths from moderate to almost perfect, from children from substantial to almost perfect, and in the case of neonates from moderate to substantial. In the case of stillbirths, the clinical information adds no value because basically there is no clinical information in these cases. In the next few slides I'm going to present the performance of the MIA compared to the CDA. Again, now blind data, so blind minimal invasive autopsy, just pathology and microbiology in the different age groups. First of all, in adults, as you can see, the sensitivity was and the positive predictive value were quite high for the different diagnoses. So disseminated infections, sensitivity was 98%, so we identified in the MIA almost all disseminated infections. For the case of pulmonary lung infections was 80%, for CNS infections was 92%, for gastrointestinal infections, although we did not have too many cases, just 2 of them, none of them were identified by the MIA. For the case of malignant tumors it was 81%, and for other diseases was lower, just 69%. So what I want to stress in this slide is that we were particularly good for infections. As you can see, the percentage of cases that were diagnosed by the MIA in case of lung infections was lower. I said at the very beginning that we have now increased the number of samples, and we try to get as many samples of the lung as possible, because lung is an important organ, and as you can see in the first CAMIA study, although we got lung in many cases, the amount of lung tissue present was very low, and consequently the number of pulmonary infections that were identified in the MIA, although it was good, was lower than for other infections. So these are the results for the stillbirths. Again, I want to emphasize that the number of cases that were included in the first CAMIA study was very low, so we cannot take very strong conclusions. But as you can see, the minimal invasive autopsy was quite good in identifying fetal growth restriction, infectious diseases, and intrauterine hypoxia, and was less efficient for intrapartum hypoxia. As you can see, there were 2 cases that were non-conclusive, and obviously the sensitivity was 100% because they were non-conclusive as well for the complete diagnostic autopsy. Regarding the neonates, we were very effective as well for infectious diseases, and we were less effective, or the MIA was less effective for preterm complications, congenital malformations, and intrapartum complications. Just to emphasize, there are some diseases, and I'm referring basically to congenital malformations. We can identify congenital malformations in the MIA only when they are external. So we will not be able to identify internal malformations. For example, heart malformations, which as you know are very frequent, will not be identified in the MIA sampling. These are the results for the group of children. So again, very efficient for the diagnosis of infectious diseases, very efficient for malignant tumors. As I stated before, we did not diagnose the congenital malformations. These 2 cases, for example, were heart malformation, and we were less efficient in diagnosing other diseases. One of the most relevant facts of the minimal invasive autopsy is that in addition of this concordance, so we identify the disseminated infections, lung infections, etc., we not only identified the diagnosis of pneumonia, but adding microbiology, we were able to identify the etiological agents of the diseases leading to death in most cases. And as you can see, so we identified tuberculosis very efficiently, cryptococcosis, toxoplasmosis, pulmonary tuberculosis, meningitis, tuberculous meningitis, and toxoplasma. So we were very efficient. The samples obtained in the MIA sampling are very good to identify the specific microorganisms causing disease, and we identified this etiological agent in the MIA in 84% of infectious causes of death. The same for children. So we identified very well cytomegalovirus, streptococcus, pneumocystis, adenovirus, Klebsiella. We identified very well as well the central nervous system infections, so streptococcus pneumonia causing meningitis, cryptococcus, and a few words about rabies. So rabies, as you can see, was not identified in the MIA, but this is because we did not test for rabies. We did not use the information of the clinical information in the MIA analysis, so the diseases were not, these two rabies were not diagnosed. However, when we used the clinical information and we tested for rabies in the brain samples obtained in the MIA, the two of them were positive for rabies. So when we add this clinical information to the histological and microbiological analysis, we increased our yield in terms of diagnosis. So this slide shows the case of malaria. So malaria was very nicely identified by MIA. We identified in the overall group 19 cases of malaria, 6 of them as cause of death, most of them as cerebral malaria. In all of them were very nicely identified in the histological analysis and confirmed as well with by immunohistochemistry and by PCR. One case was a non-cerebral, severe non-cerebral malaria, and we were not able to identify malaria as cause of death, but also past malarias and congenital malarias that were associated conditions. And this is because the MIA samples very nicely show the malarial pigment in the liver, spleen, and other organs when the malaria is present. In addition to that, in some cases we identify by PCR at low levels, the malaria parasites in the blood samples. Another example, just to show how efficient and the amount of information that we can get from these MIA samples. So this is the cryptococcal infections that we identified. All of them were identified in the MIA, and these samples that were obtained in the minimal invasive autopsy allowed not only the diagnosis of cryptococcus, but also identifying the species. We identified Cryptococcus neoformans, but also Cryptococcus gatti. We were able to determine the molecular and the mating type, and with culture we could even perform a antifungogram and recognize what antifungal agents were effective for this specific cryptococcal infection. So in addition to that, in a significant number of cases we identified on the underlying conditions. So as I said before, HIV was very frequent. 66% of our cases were positive. In many of them had very high copy numbers were identified in the analysis. We identified 6 cases with cirrhosis, most of them due to hepatitis B virus, and all these cases were diagnosed by the MIA. So in conclusion, regarding to this validation of the MIA compared to the CDA, so number one, the biological samples obtained in the MIA are adequate for pathological and microbiological analysis, and they allow to identify the microorganisms in the majority of deaths due to infectious diseases. Number 2, the cause of death can be identified in all groups with a concordance that ranges between moderate and substantial. Third, in all study groups the sensitivity is high or very high for infectious diseases. All malaria cases are identified through the CDA, were also diagnosed by the MIA, and the method allows further characterization of the microorganisms, including antibiograms or antifungograms. In all study groups, the sensitivity was lower for non-communicable diseases, although MIA was quite effective for diagnosing malignant tumors. I should say that almost all the tumors identified in these cases were widely disseminated tumors. And finally, in maternal deaths, the sensitivity is higher for indirect, so diseases not directly related to pregnancy, compared with obstetric cause of death. So the MIA, obviously, so without the use of the clinical information, is not good for diagnosing obstetric hemorrhage. Finally, I'm going to discuss briefly about the postmortem interval. As you know, in most pathology labs, autopsies are done generally within 24 hours after death. The reason is that the tissues deteriorate over time, and this may impair the results of the autopsy. However, if we put this limit of 24 hours, this short time frame may hamper the feasibility of minimal invasive autopsy when implementing the tool in some rural areas. So in a recent study, we have assessed the reliability of the minimal invasive autopsy, but also of the complete autopsy when performed later than 24 hours after death. So what we have done is to compare over 200 cases in which the autopsy was done. The autopsies were done within 24 hours, with a number a little bit smaller, 68 cases in which the autopsies were done more than 24 hours after death. So they range from 24 up to 60 something hours after death. So as you can see, and I just want to emphasize the number of non-conclusive cases. So the cases are separated in stillbirths, neonates, and children. As you can see, the number of non-conclusives does not increase with time. So we have roughly the same number of non-conclusive cases in the first 24 hours and after the first 24 hours. So as you can see as well, the distribution of the cases of the infectious diseases and other diseases does not significantly change over time. It's interesting when we evaluated the results of the microbiological study, however, that we do not see any change for the fungi, for viruses, and for parasites, but there is an increase in the number of cases attributed to bacteria over time. So as you can see, so this is the percentage of cases that were attributed to infectious death, and there is an increase over time. So this indicates that probably we are attributing some cases to bacterial diseases in the autopsies performed later than 24 hours that probably are not related to real infection but to contamination. And when we analyzed the bacteria that were mostly involved in this increase over time were basically enterobacteria and pseudomonas. So basically the message is that we should be careful when interpreting the results of the cultures and of molecular tests related to enterobacteria and pseudomonas after the first 24 hours. So the conclusions of these studies, of this study on a post-mortem interval, is that autopsy studies, including minimal invasive autopsy and complete autopsies, could be confidently performed more than 24 hours after death, provided obviously that the bodies have been kept under refrigeration. So it is something that I forgot to say, that all the bodies were kept under refrigeration. And the second conclusion is that the contribution of enterobacteria and pseudomonas are responsible of infection may be overestimated, particularly in procedures performed more than 24 hours after death. So, and we should be careful about that, because this may result in a false attribution of cause of death to this bacteria. We evaluated the clinico-pathological discrepancies between the comparison between the clinical diagnosis, the diagnosis made by the clinicians during death, and the gold standard, the complete diagnostic autopsy. And we identified in all the groups a high number of major clinical errors. When I say major clinical errors, I mean errors that, if recognized during death, this would have resulted in a better survival for the patient. Finally, to stress that this high frequency of false negative clinical diagnosis was specifically frequent in infectious diseases. So thank you for your attention.